Good day, everybody, and welcome to our 9th Clinical Engineering Association of South Africa webinar for this year. I am Helen Potgieter, and I will be representing KISA for today. This is the last webinar for this year, so we hope to see you also at our Global Clinical Engineering Day in October. We are planning it for the last week in October, and the details and dates will still be communicated. And I also just want to remind everybody that there are a couple of competitions running for the Global Day for students, also most popular CE professional, and mentorship. And we would like to see some nominees. We've received some, but we are hoping to still see a couple of entrants into these categories, and they are due on the 15th of September, so you have a couple of days left to nominate your favorites there. So these webinars are recorded and will be available to members on our YouTube channel within a couple of days, and that is thanks to Dieter, who will also be providing some technical support. And today's topic is ergonomics in the operating room, how the clinical engineer can help. This presentation is brought to us by SAFMED. The webinar will not be interactive, therefore we ask everybody to please keep your microphones on mute during the presentation, and we will at the end allow for about 10 to 15 minutes for questions and answers. You are welcome to use the chat box to raise any questions or to make comments, and I will read them out during the Q&A session. I'm going to introduce our presenter for today. Our presenter today is Zana Jardine. Zana is a clinical specialist in decontamination, as she holds a nursing master's degree from the University of Witwatersrand. Before joining SAFMED, she held the position of theatre unit manager for 10 years and has presented at a variety of congresses in her specialty areas, operating room sciences and decontamination of medical devices. Zana is the current chairperson of the CFSA, that's the CSSD Forums for South Africa. Zana represents the CFSA on the South African Bureau of Standards Technical Committee, and that is for medical devices and sterilization of healthcare products, and also is member of the CSC, the Central Sterilization Club in the UK. Welcome, and thank you for joining us, Zana. I'm going to give over to you, and you can start your presentation.
Thank you very much. This presentation is brought to you kindly today by SAFMED and SAFMED Education. SAFMED prides itself on focusing on education as a whole, as an important aspect and a part of everything that we do. So our topic today is very clinical, and it's all about ergonomics in the operating room. And we go on to think about ergonomics in the operating room as a concept, but also how the clinical engineer can actually help all of us with this very important topics. In the center of everything we do, of course, is our patient. But ergonomics affects everybody. It affects us in our home life. It affects us in our work life, as you know. And as we progress through these slides, I'd like you to think about ergonomics from different perspectives. First and foremost, the patient, because that is central to everything we do, and everything we do or don't do, for that matter, can have a profound effect on the patient themselves. I'm going to focus specifically in the operating room today, because that's where my experience lies and our area of expertise is. But remember, these principles can be applied to other departments or areas of the hospital where you do a lot of work as clinical engineers. I'd like you to try to think of ergonomics from the surgeon's perspective, from the theatre staff's perspective, and of course how you can play a role in helping the surgeon and the theatre staff to get really good ergonomics for themselves at the end of the day. Then, of course, there's you yourself, and as a clinical engineer, you too have a demanding job. You end up standing in awkward positions, doing really difficult work at a high, heavy pace, quite often. So you can also apply this to yourself in your own work, in your own circumstances. So have this all-encompassing thought while we go through our various slides in our presentation. What is ergonomics? So the term ergonomics is derived from the Greek word. It's a combination of ergon, meaning work, and nomos, meaning the natural roles or arrangements. So therefore, ergonomics really is defined as a scientific study. It's a study of people at work. It's a study of people at work in terms of equipment design, in terms of the workplace layout, in terms of the workplace environment, its safety, its effect on productivity, and its effect on a whole in terms of training. In this publication, and the majority of the published papers that are reviewed for this presentation are from 2020 onwards. And that's a point that always is quite alarming. If you're finding a lot of stuff that's recently published on a particular topic, you know that that topic is a hot issue and one of great importance. And I think ergonomics as a whole is something we sometimes forget about, but it is certainly something that's in the news or in the publications at the moment. In this publication from the Association of Operating Room Nurses, they go on to then further define ergonomics as the study, as the National Institute for Occupational Health and Safety in the US defines it. They define ergonomics as the study of people at work with the goal of preventing soft tissue injuries and musculoskeletal disorders. Just having a look at the image of our surgeon on the right, you can clearly see that the ergonomics has a terrible or profound effect on a patient and a surgeon. It is really well documented that poor ergonomics significantly increases the risk of musculoskeletal injuries and substantially, note that word, impacts a surgeon's performance quality in the operating room. This is all courtesy of the American College of Surgeons. Incorrect posture can lead to fatigue, it can lead to discomfort, it can lead to stiffness, it can lead to numbness, it can lead to back, neck, and shoulder, as well as leg pain, as well as long-term disability or even the need for corrective surgery. Certain factors inherent in our work task can actually increase the risk for the onset of musculoskeletal disorders. And they include things like fixed and constrained postures that were frequently awkward, uncomfortable, or maintained for too long a time. If you look at the image of the surgeon on the right over there at different angles, you can clearly understand that surgeons can end up in strange places and strange positions and can really and truly be in those positions for a very long time. But then again, so can a clinical engineer. I'm sure you can find yourself in an awkward position trying to fix something under difficult circumstances, no matter what department you're in. Another important thing that increases our risk is repetition and forceful hand movements. As clinical engineers, you use your hands often. Surgeons, of course, use their hands often as well. And there are certain things that are quite repetitious, and we just have to keep doing and keep doing and keep performing. A high pace of work is also something that puts people at increased risk for these kind of musculoskeletal disorders. Then we need to take into account people's medical conditions. So people with medical conditions like arthritis or diabetes or even thyroid disease are at greater risk for developing these kinds of disorders. And then individuals who smoke are at a greater risk for especially hand-arm vibration syndrome, and that's generally due to a decreased blood flow, which is normal in smokers, so not an unexpected concept. So repetitive work is something that really plays a strong role. From a company background, for example, I don't know if you've ever seen the Biodic test. Those Biodic tests that Sapien cells are actually manufactured in our facility, our ISO accredited facility in Cape Town. And when you compile the actual test, the individual who does the work has to use their hands continuously, and it's a very repetitive task. So as a result, we need to manage that by rotating the staff and making sure that they're quite careful with their own ergonomics. As I said, applying ergonomics in the greater perspective from the patient side, from the surgeon's perspective, from the theatre staff's perspective, and from in our own home and work life scenarios. Ergonomics in laparoscopic surgery. So here's a nice publication from the World Journal of Gastrointestinal Endoscopy. This publication talks to the fact that a significant number of laparoscopic surgeons suffer from work-related musculoskeletal injuries, up to 70%, they say. And they say that as such, ergonomics are pertinent to laparoscopic surgery, more so than probably open or even robotic surgery. That's their viewpoint. Laparoscopic surgery, of course, is really beneficial for the patient. The patient will recover quicker generally. They generally have less pain. They generally have less chance of infection. And generally speaking, they're able to return to work quite soon, or a hell of a lot quicker than if they had open surgery. But laparoscopic surgery as such is really not easy for the surgeon from an ergonomics point of view. And the fatigue among surgeons and assistants may increase the risk of error during the procedure, and hence every effort should be taken to improve the ergonomics. And I think we can truly play a role in that as a whole. So simple things. I mean, they're logical, to be honest, but we tend to forget about them. The position of the monitor is very important in laparoscopic surgery, and that position is actually going to be dependent on the size of the screen that's being used. That plays a role. Ideally, a monitor should be between 90 to 200 centimeters away from the surgeon in a straight line across from the surgeon's view with a slight gaze down view. Important concept. To be able to do that, we need some form of equipment, either a pendant or a trolley system or a monitor at the end of the day that is mobile, that we can move from one area to the other. And not only about the fact that it needs to move, it's also the concept of how hard is it to move, and is it stationary, is it stable? Very important concept to figure out. Also important that the table height and the operating table height is adapted to the surgeon's height and the surgeon's position. The table height should be adjusted in such a way that the laparoscopic instruments are just slightly below the level of the surgeon's elbow. And of course, the elbow should be flexed at about a 90 to maybe 120-degree angle is the recommendations when it comes to laparoscopic surgery. You can see in the neutral posture image over there where they talk about what the correct angle of the elbow should be depending on what type of task that you're doing. A neutral position for something that requires a bit of medium force or energy. If it's a fine task, that the angle is a little less acute, and a greater or more acute angle if it's a really heavy task. Very important. All of these things in themselves add up to the long-term longevity and patient safety at the end of the day. If the surgeon's happy, the surgeon will perform better surgery, better quality surgery, and we get safer patient care. The American College of Surgeons demonstrate the difference between the recommended table height settings for laparoscopic surgery versus open surgery. You can see on the right over there that the surgeon's angle, elbow angle is at 90 degrees, with the patient, of course, a little bit higher, relative, of course, to how tall the surgeon is or how large the patient is. All of these things, again, have to be taken into consideration. We can solve the problem sometimes, of course, by putting the surgeon on a footstool, but footstools can be a little bit uncomfortable. They can be a bit daunting. It's possible to fall off them. It's quite difficult to work with a diathermy foot pedal when you're up on a footstool as well. That can really be awkward and problematic. I had a surgeon once step back off a footstool during neurosurgery. He got caught up in the suction unit. He then got up off the floor, threw it across the theatre, had to change and start his procedure again. So all of these things have a profound effect on the outcome of the surgery, and of course your own health. The table height for laparoscopy, as you can see, is a little bit lower, and that, of course, then also allowing the monitor's height to play a role, and then allowing for the length of the actual instrumentation, bearing in mind, of course, that laparoscopic instruments are quite long. And if you're doing things that are related to really obese patients, it can make it quite awkward to get to the right table height. Important that the instrument themselves are actually inserted, at least half of the instrument inserted inside the patient. There are a number of different reasons for that, including the ergonomics, and also about being able to see where the instrument is from a safety perspective once you're doing the surgery. If less than half of the instrument is inside the abdominal wall, it'll create excessive motion at the shoulder height, and that's likely to fatigue the surgeon even sooner. A tired surgeon with hands that aren't working properly means greater risk for the patient. The College of Surgeons also talk about the importance of correct light placement. And I'm sure over the years, you've all been exposed to the operating room where light placement becomes very, very important. We sometimes get our lights a bit tangled up in the theatre. Sometimes we knock them together by accident. When we're trying to get everything in the right place, we all get a little bit impatient. Then the anaesthetist steps in and the theatre staff, and maybe the surgeon's able to put on a light handle and do some of the adjustments themselves. But correct light placement is important, because improper lighting and improper display orientation has an adverse effect on performance, can also cause eye strain, and certainly musculoskeletal fatigue. You don't want the surgeon leaning off to the one side the whole time to try to get their head out the way of the light so that they can actually see what they're doing. The College of Surgeons also go on to say that we need to ensure that open surgical field, that you've got high light or high illuminance, of course, and using 2 or more lights at different angles are recommended. Place the overhead lights between the surgeon and the assistant is the guidance that they give where possible. Of course, in most cases, it just depends on the overall position of the patient. They talk about avoiding creating shadows from a single light source, which of course can happen from the surgeon or the assistant's head. And then for laparoscopic surgery, they talk about the importance of dimming the room lights so that you can reduce the glare and the contrast. Not all surgeons do that. Some don't worry to actually reduce the room lights, but it seems that it could have a beneficial effect on them. I'm now going to play an interesting video, and this video is, as you can see, after a quick Google search, I came across this presentation, as you can see, by these 3 doctors or medical professionals, and they focus on physical therapy as such. And so if you have any issues listening to or hearing the video, it's possible that your bandwidth might be a bit tricky. Please don't stress. I'm sure on the recorded version, you should be able to see the complete video. It's about 8 minutes long. Have a look at this one.
A variety of operative approaches are available for gynecologic surgeons, including laparoscopic, open, vaginal, and robotic, and all require the surgeon's body to move through and maintain a variety of positions. The physical nature of surgery necessitates an awareness of ergonomic principles. However, adequate knowledge of such principles has been reported to be as low as 11% among practicing surgeons. Findings in the literature, based primarily on reports of general laparoscopic surgeons, indicate high rates of neck, shoulder, and back pain, as high as 89% in one study. Sadly, for many surgeons, pain is seen as part of the job rather than a warning that postural and environmental adjustments are warranted. Fortunately, many of the factors that contribute to the pain surgeons experience can be improved through education, modification of OR setup, and changes in surgeon posture. The following elements of the operating room environment must be considered: monitor position and height, table height relative to each surgeon, placement of arm boards, and location of foot pedals. The position of the monitor directly affects back and neck posture for all surgeons involved. The display should be directly in front of each surgeon, 15 to 40 degrees below eye level for maximum comfort. Higher monitor placement requires the surgeon to compensate with extension in the cervical and possibly lumbar spines. When determining proper table height, The additional height contributed by the patient's body must be considered. Table position that is too high requires the surgeon to make unnecessary compensations through the shoulder girdle that create increased load and mechanical disadvantage. Table height should be adjusted to allow 90 to 120 degrees of elbow flexion. In some cases, this may require one or more surgeons to stand on steps. The common practice of placing arm boards at 90 degrees from the patient's body can challenge the surgeon's ability to achieve and maintain optimal ergonomic posture. When possible, tuck the patient's arms, which allows for more natural and ergonomically sound surgeon movement. Foot pedals should be placed next to the surgeon's foot and aligned with the target instruments toward the target quadrant. Positions that cause the surgeon to twist the leg or body should be avoided, and assistance may be required to readjust the pedal position. If the surgeon is standing on a step, the pedal must be at the same level off the ground. Along with this basic understanding of the ergonomic importance of proper OR setup, 3 common ergonomic errors in surgeon posture will be presented. These include forward head posture, sustained and awkward shoulder elevation, and asymmetry in weight bearing. Head forward posture is a common cause of tension and pain in the upper body. It can accelerate degenerative changes, particularly in the mid-cervical spine at the segment supplying the shoulder girdle. For every inch the head moves forward in space, its relative weight increases by 10 pounds, upping the demand on muscles and joints for adequate support. Developing a practice of habitual postural resets is recommended. Excessive and sustained shoulder abduction and internal rotation is non-optimal for many reasons. This position requires the greatest workload from the deltoid and trapezius, creating a mechanical disadvantage and predisposing to fatigue and injury. The postural reset here is to drop your shoulders and relax the hands. In the OR, surgeons commonly shift their weight and will stand on one foot, frequently due to foot pedal use. However, this habit can have significant implications for the pelvis and lower back. When the majority of the body weight is on one lower extremity, excessive shear and load in the structures of the lower extremity and spine can result, contributing to pain and injury. The proper position to avoid these issues is to keep the feet approximately hips width apart. Avoid shifting weight to one hip. Be sure not to lock the knees. Rather, when weight is shifted asymmetrically, gently engage the deep muscles of the trunk and pelvis to maintain a neutral position. Footstools can be used, provided that proper pelvic and lower extremity position is maintained. Again, avoid shifting weight to one hip, which leads to asymmetrical loading through the lower extremity. Given the sustained nature of many surgeons' postures, it is helpful to periodically move the body into counterbalancing positions during any natural breaks in surgery. An arm raise, as shown here, uses full shoulder elevation, external rotation, and scapular depression and retraction to counterbalance the habitual upper body positions previously described. Draw the scapula down and back toward the middle of the back as the sternum lifts slightly with bilateral or unilateral arm raises. Squatting, as if sitting back to a chair, is an easily performed multi-joint functional exercise that engages the large muscles of the lower body and reinforces symmetrical weight bearing and neutral spinal position, all without compromising the sterility of the operative field. It has been suggested that robotic surgery confers ergonomic benefits for the surgeon over both open and conventional laparoscopic surgery. However, proper attention must be paid to ergonomic principles while the surgeon is seated at the console. In particular, proper posture and upper extremity position at the console are crucial in order to avoid neck, back, and arm strain. The robotic console requires the forehead to rest on pads while viewing the operative field through the 3D high-definition vision system. The forearm should rest comfortably on the arm supports, the torso should be erect, and the feet should be comfortably placed on the floor. If adjustments are not made to the seat and console height, the surgeon may be forced into an awkward position of the spine, neck, and upper body. Without proper adjustment that is individualized, forward head posture and improper shoulder positioning will result and be sustained throughout the case. Adjustments of the seat height and proximity to the console can yield marked improvements in posture without compromise of the visual field. To avoid muscle strain and fatigue in the shoulders and elbows, it is crucial for the surgeon to remember to keep returning the arms to the arm supports and to frequently engage the clutch mechanism on the hand controls. We suggest that consideration of OR setup, proper standing posture, practice of postural resets, and regard for sitting posture and upper extremity position during robotic surgery are necessary components for a longer, healthier, and pain-free surgical career.
Alrighty. I'm sure you've already started to think of what role you can play as a clinical engineer in improving things. And of course, you do play an important role already in the setting up of theatres. You may be involved in the design and the layout of some of the departments. You often make decisions on the types of equipment being purchased. You may be the one whose task it is to prioritize the capital equipment budget. And if the staff are asking for pendants or for footstools or something, or specific lithotomy poles, perhaps now you'll understand what's driving some of their requests. Of course, when you're making any of these types of decisions, it just makes good sense to consider the ergonomic impact of what you can do. And hopefully, if you put yourself in the shoes of the end user, you can understand that. When you're considering or designing a theatre for laparoscopic or endoscopic surgery, or you're involved in anything like that, it's quite obvious that you need to ensure that the monitor arms or the whatever's the camera stack on the pendant, that these things don't clash, and that it doesn't clash with the lights, for example, that there's enough movement and enough space for all of these things. There are, of course, many advantages to having equipment permanently installed. Generally, it's going to reduce connection errors, less chance of the theatre staff is going to say, us nurses, we can break things. We're really good at that, especially when we tug on cables and don't remove them from the plug, but pull on the cable instead. So having most cables or power supplies or network connections, gases, etc., coming through ceiling-mounted power booms creates a lot more free space in the operating room, potentially reduces the error for damage or for us actually making mistakes. Of course, it's going to be a lot safer in terms of the floor, that we don't trip, reducing trip hazards. And at the end of the day, it's going to be greater or better for the ergonomics of everybody in the operating room, both moving the stacks and, of course, being able to position them in a way that works easily. And if they're on hydraulics arms and stuff like that, it's a little bit easier, less physicality to actually get them in a place that's suitable. Simple things like plug points and connections and cabling, knowing what you want on the arm is very important. Knowing how many things you need to plug in from a certain direction is important from the get-go, so that that the supplier can ensure that you have everything you need up front. A lot of these things are you can make slight adjustments to them, of course, depending on your needs. If you're not that fortunate enough to have fancy stacks mounted on pendants, which hopefully is something you can get to in the future, and you need to put stuff on mobile trolleys, then obviously the trolley that you choose matters. Having a monitor arm that's got a wide range of motion will be important. Being able to lower it or raise it also is very important, or having to be able to rotate the arm from one side to the other. Or even being able to shift the arm, that you can put it in a different area, mount it in a different area on the trolley itself, so that you can get lower positioning. Remember, of course, in ENT or surgeries where you might need to be seated, you have to take that into account. So that's why some surgeons are quite concerned about having a monitor that can go really, really low in the seated position. Of course, logically, you would have already thought of casters on the trolley. I'm sure some of you in your lifetime may have experienced the odd nurse or two pushing things over, or crashing into something, or having issues like that. But remember, the easier it is for us to maneuver, the safer it is, or perhaps the less chance we're going to bash into something else or cause any damage in the operating room. Remember, we've also got time constraints, so we're trying to do what it is we do in a bit of a hurry. Always better to try and make things as nurse-proof as possible. Just looking at the lithotomy position, for example, we saw in the video earlier, we spoke about gynecology, and you saw the angles at which the surgeon ended up. But remember, when it comes to ergonomics, in no matter what patient position it is, I'm just using lithotomy as an example, there are three perspectives. There's the patient's perspective, there's the surgeon's perspective, and then there's the theatre staff's perspective. And all of these have an impact on the outcome. When we're positioning the patient, there's so many things that the guidelines tell us. Of course, they're going to say we want the patient in padded stirrups. We want to make sure that we don't cause any nerve damage. We've got to be very careful with the placement of the arm board. Where possible, we want to be able to tuck the patient's arm in, but how we tuck the patient's arm in also is very important. Of course, we don't want any excessive flexation, rotation, or abduction, or of the patient extremities. And of course, we want to make sure that they still have pedal pulses, there's still blood supply to all of the areas, and we don't damage any nerves. So when we're doing this job, we take it hell of a seriously, but it's also quite physically demanding. Now, once you get the patient in the position, you often have to now maneuver them, that their bum moves down a little bit more so that they're at the right break of the bed, but not too far down. All of this requires a lot of physical input from us, but at the end of the day, to protect the patient. This published paper, called a multidisciplinary focus on musculoskeletal disorders among operating room personnel. Logically, it states that pulling, pushing, or lifting surgical instruments, heavy and specialized surgical equipment, and patient position are the most common manual activities for the operating room staff. And that due to difficult working conditions in the operating room, musculoskeletal disorders are really common amongst the operating room personnel. Statistics show that 7.5% of all nurses are absent from work each week due to physical disabilities. Something that you could perhaps help a little with. This journal article in the AORN, the Association of Operating Room Nurses, goes on to talk about the fact that perioperative leaders have to consider the design issues, especially when you're deploying new equipment, and you need to consider what the additional ergonomical demands will be that you're placing on the staff on the decisions that you're making. They quote some much earlier statistics about high rates of disorders, musculoskeletal disorders, and injuries to the neck, the shoulders, and the back. As you can imagine, in the operating room, those are quite common. And then, of course, my other interesting things to think about are these risk factors. So lifting and moving patients and equipment, supplies, all relevant. We understand that. Multiple lifts per shift. So if you think about urology lists, or you think of gynecology lists, especially when there's lots of legs up and lithotomy position happening, and lots of patients throughout the day. So it's not like, long cardiothoracic surgery that the patient's on the table for a couple of hours. You're doing 15, 20 patients a day. It's 50 or 20 patients you've got to lift in a multitude of different positions. That's quite tiring. Of course, there's twisting, using inappropriate body mechanics, even prolonged computer work is a risk factor. Working in unsafe physical settings is a risk factor. Working with wet floors, working with inadequate lighting, all of those are potential risks. Using broken equipment, again, another risk factor for these ergonomic challenges. And wearing lead aprons. So I scrubbed for urology for a number of years and wore lead aprons continuously. So if any of you are working with or involved in lead aprons, please just think a little bit clearly about the ergonomics about wearing a lead apron. We need them, but there are ergonomic issues around it. Let's just have a look at this basic table or this theatre setup. As you can see, staff have started to get the theatre ready for this procedure. At the moment, they've put both sets of leg irons or patient leg supports on the table, and of course there's that heavy table legs. Ideally, if we can avoid having to remove and replace the table legs the whole time, let's see what we can do to make this a little bit easier for the staff. We would have had to have gone to the storeroom, which is where, depends of course on the layout and the design. If you think about that, to get this equipment from somewhere. How did we do transport to the operating room? Then of course we've got 20 cases on the list, so lots of lifting. You can maybe make it a little bit easier by, of course, having these like hydraulic type lithotomy leg supports, because it requires less physical energy from our side, from the staff side, to be able to lift and lower the leg support, nicely padded and cushioned from a patient safety perspective, and perhaps something like a lighter transfer board. So the transfer board in the picture is an example that makes it a little bit easier, instead of the staff having to take out those heavy legs the whole time. How do we get the equipment to the operating room, or maybe making use of some form of cart, which of course is a concept to think about, because we need to get the stuff from one point to the other. Maybe having a cart might make it a little bit neater, and maybe we'll put the stuff back where it's supposed to go, not something that is always done. Of course, otherwise we end up with the stuff at the base of the bed. As you know, and that in itself has terrible risks. Not only the risk to the table itself, which we often graunch as a result of all the stuff we put there, but we put it there out of convenience because it's quick to grab, not necessarily ergonomically the best area either, because that requires a low lift. We've got to go down low to lift all of these heavy items. The AORN talks about perioperative team members that stand in the same position for longer than 2 hours, continuously that is, or for more than 30% of their working day, should use some form of fatigue-reducing techniques. And that should also apply to clinical engineers, in my opinion. And what in the operating room do they refer to? They talk about determining ergonomic placement of the monitors, altering the height of the bed, alternating propping of your foot on one footstool, wearing supportive footwear, or perhaps the use of anti-fatigue mats. So what about the clinical engineer? Because the clinical engineer is also at risk for work-related musculoskeletal injuries. Sometimes you end up in awkward positions, as we've spoken about before, or you might be in the middle of doing some fancy stuff that requires you to sit at your desk for long periods of time because you're ordering things or looking at things. Both of these can be quite problematic. When you are sitting at a desk, of course, very important is the position of your wrist, and your wrist should always be in a neutral position. If you have a look at the image on the top over there, you can see that the individual at the desk has got her wrists in a really awkward angle. So just think a little bit about your own ergonomics, how to keep your wrists neutral. Keeping your wrists in a neutral position when you're pushing or pulling stuff also matters. You may need to push or pull some equipment around. Note the difference of the images on the top and the angles of the wrists and the images at the bottom. Quite a distinct difference in terms of how to do it a little bit safer. Another important concept is lifting, and when we're lifting stuff, it's very important that we stay in the power zone. We can apply that to when we're lifting things off the floor, when we're lifting table equipment, for example. It's always very important that we try to stay in the power zone. Of course, the power zone is about lifting a little bit closer to your body, and the importance about being mid-thigh and mid-chest. Got a little video here that describes that a little bit more clearly.
The power zone, which may also be called the safe zone or comfort zone, is the area within your range of motion that gives you the maximum strength capability with the most comfort. It is the zone close to the body between mid-thigh and mid-chest. This is a zone where arms and back can lift the most with the least amount of pressure. It's similar to the strike zone in baseball. Employees have fewer injuries when working in the power zone, and they can maximize the strength and comfort and minimize the forces applied to the muscles and joints. It's not always possible to work within the power zone 100% of the time. But the more you can shift a task to this area, the more effective and safe you will be in your job.
So when I'm lecturing on CSSD and CSSD storage, I talk about the importance of where you put the heavy sets. Now, in CSSD, sometimes we want to group all of our stuff together, put all the Gynae together, or the ortho together, or maybe you do it in alphabetical order. Whatever method you use, it's quite important to try put the heaviest stuff at around waist height, and we're putting that in the power zone. Ultimately, you can only imagine the strength that it must take, the higher you must lift from when you're trying to do something with a heavy object. Also, a little bit easier if you can use a bit of a sliding mechanism to help you lift and carry these heavy sets. If you think about it, the heaviest set I think I've weighed at the moment is around 18 kilograms. But some of our packs and trays, some of the orthopedic instrument trays and spinal trays can be extremely heavy. And the volume of these items that we must lift in a given day is something we really and truly need to take into consideration. Well, and then the last one I'd like to think about, or let us all think about, is ergonomics of the desk. Now, every time I watch this video, and I've gone through it a few times in the last 3 days, I find myself rearranging myself in my chair. So this could be quite interesting. If you find yourself shuffling a little bit, it's for good reason.
Here's your desk. Your chair, monitor, keyboard, mouse, phone, a plant? Sure. Problem is, your desk isn't really built for you. It's for anyone. Spending 8 hours a day reaching, slouching, or craning can lead to pain. At least that's what John Sinkay from the Hospital for Special Surgery says.
I do say that every day.
So he's here to, well, he can tell you.
I'm here to show you how to set up your desk ergonomically so you can avoid pain later on in life. Step 1, adjust your chair. The average desk height is 29 to 30 inches tall. For some, this could be too tall or too short. That's where your chair comes in. The first thing you want to do is adjust the height. When you do, make sure your elbows are bent to 90 degrees. So if a person's feet are not touching the floor, this could become an issue. So we're going to give her a footstool. If you don't have access to a footrest, we recommend using a ream of paper. Step 2 is adjust your monitor. The tip is to have the monitor close enough, about arm's length, so you're able to read without having to strain your eyes or to bend forward and adjust your posture. So what you want to do is raise the monitor up till the top of the screen is eye level. If your monitor is not adjustable in height, use your reams of paper. Much better. If you work from 2 monitors, consider how you use them. If you have a primary monitor, you want that directly in front of you. If you use both monitors equally, you want them lined up so you are in the middle of the 2. For a laptop, you want to use a kickstand to raise the screen up to the proper height. Then you can attach an external keyboard and mouse to it. Step number 3 is to mind your mouse and your keyboard. Where your hands end up is where your keyboard should be. Your mouse should end up right next to your keyboard. You want to move from your elbow instead of your shoulder to prevent overuse or strain or pain. The key is not to reach for your tools. Step 4 is to position your phone. You want to put the phone on your non-writing side so you don't have to cradle it to your shoulder. This could eventually lead to neck pain. If you're on the phone a good portion of your day, you want to consider using a headset. That way your hands are free to write down anything or to type on the computer. Step 5, move. After 10-15 minutes, we all begin to slouch in our chairs. So here are some basic exercises you can do while sitting in your chair. The first exercise is a chin tuck. The second exercise is for your upper traps. You're going to do a basic stretch where you bend your head to one side and then gently pull for a little more oomph. The third exercise is called a scapular retraction. You basically are going to squeeze your shoulders back. The fourth exercise is for your lower back. This is what we call a pelvic tilt. The most important thing you want to do is get up out of your chair every hour. Get up and walk. Get something to eat. Get something to drink. Just get up.
John, are we done?
Yeah, we're good.
Great.
Alrighty. Alrighty, so thank you very much for joining us today. Hopefully this presentation just gave you a little bit more insight into the ergonomics in the operating room from the perspective of the surgeon and from the perspective of the theatre team. And then I hope you can apply these principles in your own daily life and in other areas of the hospital where I'm sure you can at the end of the day have a profound influence in things and how they go. Thank you very much.
Thank you, Zana. That was quite interesting. I think I'll get a couple of reams of paper. While we were sitting here, we were definitely adjusting ourselves. Okay, so we've got, I've got a couple of questions that came through to me directly. There's one that I'm going to just combine because it's very much in the same line. The one asked about the position of the surgeons, and most of the presentation was based on a standing position. And although there was some reference from the sitting position when using a robotics, what would be the things to consider when a sitting position is used during a procedure in theatre? Because there's usually not a support for the arms during a procedure like that. And then there was another sitting question. What are the dangers of prolonged sitting? So maybe we can combine those two, and then I'll go over to the next one if you would like to respond.
Okay, thank you for that. So yes, sitting for a long periods of time for anybody is extremely disastrous. There's lots of work and comments in the media lately about people, just sitting binge watching television for hours on end, and how that has a terrible potential profound effect on your overall well-being. Last year we had a podiatrist come and lecture at our conference who spoke about the importance of walking, that walking and movement on your feet played a big role in your vascular system. So sitting for prolonged periods is not just about awkward positions and ergonomics, it's about your overall general health. That's also part of why you want to get up every hour and not just about rearranging your position. So getting the right position for the surgeon it is now really going to depend on the type of surgery, isn't it? Because that influences everything. If you're doing eye surgery, the eye surgeons are very well trained normally, and they often will ask for a very specific type of chair, one that's got like a border, like an arm rest on it, that we would drape as part of the procedure so that the surgeon can keep their hands very, very still. You saw in the earlier diagram at what angle we want the arms to be in when you're doing fine work and fine positioning. So the type of chair is going to matter. So looking at the right type of chair, one that's definitely adjustable in terms of height. So just using stools and those kind of devices aren't always the right thing. If we're using a chair with an arm back, which we may very well do in certain surgeries, we will know how to drape it when and if required. Not an easy answer as such, but hopefully we can make it a bit easier for the surgeon.
Thank you. Then we had another question. What about the equipment storeroom in theatre? Is it always untidy?
I think the equipment storeroom it's a disastrous area potentially, and half of that relates to the ergonomics around putting the stuff back or taking the stuff out. As you can imagine, the heavier or the harder it is for the person to get the item into the storeroom, the less chance of them actually putting it in the right place, the more chance that the item's going to end up somewhere on the foot of the bed. So storerooms, as we know, and we don't know where they're positioned. They could be quite a distance away from a particular operating room, and that can just add to the physicality of the day's work for the theatre staff. And the harder it is, the less likely we're going to do it correctly. So if you can just take into consideration when you're doing any form of purchasing or arranging or designing or trying to choose some form of equipment or supports that go with an operating room table, that you try to consider making it easy as possible from an ergonomic physicality point of view for the staff, and hopefully then they'll do the right thing and put stuff away correctly. Thanks, Ellen.
So those were the three questions. Adita, I don't know if you've received any additional ones privately, but if you haven't, then we are done. Thank you very much, Zana. We do appreciate your time, and it was very informative. I definitely learned something. There's a couple of things that would have been very helpful if I knew it 20 years ago. But thank you very much. That was fantastic. Thank you very much for everybody attending, and I hope to see you last week in October.